as well. So I think
Thanks. Thank you
this
so
has
much
been
for
a
inviting
program
me.
that we have run for the last 1.5 years, and we are glad that Dr. Neeraj Adkar, who is a senior joint replacement surgeon from Pune, has agreed to talk about the TIbial defects. And what we can do is listen to his talk, take the questions on that talk, and then we will invite Dr. Leo for his talk about DVT prophylaxis. So please go ahead, Neeraj.
Thanks, Mahesh. Once again, I'd like to thank ISHKS and Pachori sir, Mahesh for this opportunity. So these are the typical Indian patients. They often present late to some issue with this. Yeah. So often present late to clinician and with such gross deformities where you find a lot of defects on the tibial side, especially posteromedial tibial side, and balancing these knees is extremely important for long-term survival of the implant, and most important in that is correction of that defect or filling those defects. So how do we approach this complex situation? So on the tibial side, in varus knee, the posteromedial aspect, deformities, and on the in valgus knee, you get on the femoral side. So we can classify these deformities. There are various classifications, but this Anderson Orthopaedic Research Institute AORI classification is most used. And primarily this is for a revision scenario, but this is applicable in primary TK as well. So as you can see in this, with the type 1 is minor defect, which is not compromising on the stability of the component. Type 2A is a metaphyseal bone damage and affecting one of the condyle, either femur or the tibia. And type 2B is it affects both the condyles. So in type 2, it actually it is a metaphyseal defect which compromises the implant, and where we need to provide additional stability for long-term survival of the implant. And type 3, it affects the epicondyles, collaterals are also affected, and sometimes patellar tendon is also geoparadized, affecting the extensor mechanism, tibial tuberosity. So this is how the type 1 patient would be. So it is a small defect. It is many times it is a contained defect, and which can easily be treated with cement, less than 10 mm, with just cement. The sclerotic portion, you can drill with small K-wire and then fill with the defect. You can use screws for additional stability in some of the defects. Tibia undersizing is one of the options here, where you can lateralize the tibia and undersize the tibia to minimize this defect. And so this is how you tackle this type 1 defect on the tibial side. And this is a standard varus knee dealt with the cement augmentation. Other option in such cases is you can resect tibia, maybe 2 mm extra, which reduces the bone defect, and definitely it improves stability of the tibial implant. Type 2 defects, as I said earlier, these are the metaphyseal defects and may affect one or both the femoral or condyle or the tibial plateau, and they require reconstruction to maintain implant stability. So what are the options with us? I mean, grafts are preferred way. Either most common is autograft, resected from the femoral condyle or from the tibial condyle. And they're preferred in young adults with good bone stock, relatively young adults. Elderly patients, which is the case in most of our cases, because these patients undergoing these surgeries are senior citizens with poor bone stock. metal augments are used, but all these patients, we must use extension stem that is required to provide additional stability. We just cannot get away with putting the graft without stabilizing the tibial base plate with the extension stem. And some of the patients, we may need semi-constant implants to provide additional stability. Cones and sleeves are rarely required in such cases, but we must keep these options handy on table in case required. Then we should be in position to use this. So the oblique wedges are no longer used, but one of the patients I had operated maybe 15, 16 years ago. And this is how one can address such deformities. Another patient with defect with stress fracture and with grafting, impaction grafting on the medial side and extension stem to stabilize the stress fracture was used. Another T2F2 deformity where huge defect on the medial tibial plateau, where you can do grafting on the right side. I could get away with undersizing the tibia and impaction grafting. Left side, I had to fix it with the 2 screws, and extension stem is used in both the cases. So this patient, pre-op, immediate next day, and around 4 weeks post-surgery. So with proper balancing, you can get good result. But as I said, correction of the deformity at the same time, stabilizing the implant and providing a stable platform for the tibial implant is extremely important for long-term survival of the implant. Another patient, T2F2, where on the right side deformity was more, and impaction grafting with offset stem was used. So coming to last type here, T3AC, where epicondyles are also involved. Typically, we get this in a revision scenario and rarely in primary TK. Here, in such cases, ligament, there is instability, and sometimes patellar tendon is also affected. So revision cases where it's huge defect, we need to use sleeves, and most of the patients hinge or constraint prosthesis. But friends, we must remember, whenever we are dealing with, let it be a revision scenario or a primary, we must get stable fixation in at least 2 zones out of 3. That is at the surface or at the metaphysis or the diaphysis. And based on the good bone stock, we must plan our implant accordingly. And so sleeves are made of titanium and they are porocoat, and they really give good metaphyseal hold, and which helps in bone transfer through these sleeves. Even if there is defect in the at the surface at the epiphysis level, the sleeves, with the help of sleeves, you can bypass that, and that really gives the good hold in the metaphyseal region. At the same time, they help in restoration of joint line. And so they provide axial as well as rotational stability, and they're excellent in metaphyseal defects. One good thing about this is they are independent of orientation of the components. So we have, play around 20 degrees. So wherever there is good bone stock, in that direction, you can implant the sleeve, and it's very easy to implant the sleeve, and not very time consuming. So 67-year-old male, revision scenario, post UTI infection, explantation was done somewhere else, and this is how it presented to us. And huge defect on the femoral as well on the tibial side, and with the help of sleeves, we could mobilize them very next day. Another patient post explantation and with sleeve, and on the both the sides, femoral as well as in the tibial slot. So friends, less than 10 mm defect, you can get away with undersizing or resecting the tibia slightly more, maybe 2 mm, not more than that, and then cement or with or without screws. More than 10 mm AORI T2F2 bone graft stem is mandatory in such cases. Wedges or constraint implants if required, we must keep it ready on table. And AORI T3F3 sleeves and hinge implant is recommended type. So I thank you for your patient hearing and like to answer any questions if any. Thank you.
Thank you, Neeraj. I'm going to check the chat box once. There are not many questions, but I wanted to ask you, what do you think is the main difference or indication for usage of sleeve or cone? Difference between usage of a sleeve versus a usage of a cone according to the indication.
So, Mahesh, the metaphyseal defects, you can use this, and I have honestly very little experience on the cones, but sleeves I've been more familiar with and happy to use those implants, and they're so. For me, I mean, there is no actually gross difference, but wherever possible, I use sleeves. So maybe you can update us on that.
Next question is how to intraoperatively determine the diameter of the stem to be used in revision.
So you can start reaming canal, and so there are two types of stem. I mean, uncemented and cemented. So uncemented stem, whatever the best fit reamer, maybe 0.5 mm. It is slightly thicker than that actual trial stem. So uncemented, I go with the best fit reamer, the last reamer. Cemented, I prefer to ream slightly extra and fill the canal with the cement, if at all we use a cemented stem.
Okay. Yeah, the sleeves and cones is always a debate. That is an ongoing debate. But in my understanding, I think the sleeves become part of the construct because the sleeve attaches to the more step as a more stepper with the stem of the implant, and then it shares the load transfer from the implant to the bone, whereas cones usually are used only to fill in the defects, and they fill in the defects, but they are not directly transferring the load from the implant into the bone. So I think in a way, sleeves will be load sharing implant as compared to the cones.
Mahesh, if I can just add a small point to that, would you consider using a sleeve when there is a cortical defect? If it is a contained defect, sleeves are fine, cones are fine, sleeves are fine. But if it is an uncontained defect where there's a large cortical defect, then sleeves probably may be the better option, right? The cones may be the better option, right?
Yeah, if you're not going to get press fit with a sleeve, then I think it will not be useful.
Yeah.
Leo,
then you have to use
I mean,
to purchase the diaphysis.
Yes. Couple of cases where there was a periprosthetic fracture and tibial side, and we could get, so we kept everything ready on table and we could get excellent hold for the sleeve. And still, so there was a breach and just beneath the tibial, keel, you can say. And so such cases also, if, as Mahesh said, you get a good hold, then we can still use, consider sleeve in such cases.
Okay. Think anything else? And are you following the principles of zonal fixation, which has been put forward by the group from London, Faris Haddad and group, where the TIbial is distributed amongst three zones. One is the surface, then the metaphysis, and the diaphysis. And do you follow that principles in your practice for revisions?
Yes, as I shown in the presentation, there's at least 2 zones we should get good fixation, and probably that gives good stability for that implant. Sleeves with uses of sleeves, that has solved our problem. We get a good hold in the diaphysis with the stem and sleeve in the metaphysis. So even if there is a defect in the surface at the epiphysis level, that is not much of a concern. So 2-zone fixation is a must for me.
Okay, thanks. Any further questions, Dr. Pachore or Leo, or you want to add something? Pachore sir, anything you wanted to say or add? It's on mute, sir. Your volume is on mute, Pachore sir. Yeah, yes. Now it's okay.
I think, Neeraj, this is the primary TKR posterior medial. These are usually posterior medial defect, not the anterior defect, because of the continuous subluxation.
Yes.
Subluxation. Yes. And to create that, I think we have to mention Dr. Maniar's work on this, which has been approved by the American Association and various international, his technique of getting the graft has been well accepted if the defect is about 10 to 15 millimeter. And that is one. And you add whatever you have mentioned very clearly. If this more than 10 millimeter, I think you need a stem. Even at least short stem is also all right for a small defects. I totally agree with you. Putting the screws, one important message I would like to give is don't put horizontal screws. Put a slightly oblique vertical screws, because that is the area of the loading there. If you put a little transverse screws, chances of getting a fracture are very high. So that is one more recommendation, that you may not put a 90 degrees, or not possible because of the defect, at least 60-65 degrees. And one screw is not enough at all. You must add 2 screws, minimum 2 screws, otherwise you can't stop the rotation. And the healing of this graft is excellent, because you are on the compression force, and it is not like in the hip, which have got a shearing force. So the union is extremely good in this in this area. So that is one important message I would like to pass on.
Yeah, thank you very much, sir. So thank you, Neeraj, for your presentation and teaching, and we appreciate your time as well as the efforts to teach these youngsters. Now, I request Dr. Leo to talk about prophylaxis of deep vein thrombosis, which is a very important topic for not only from the exam point of view, but in daily practice as well. So, Leo, please share your screen. Dr. Leo is...
are you able to see my screen?
Yeah, we can see your screen. Dr. Leo is a renowned surgeon as well as secretary of the Indian Society of Hip and Knee Surgeons. He comes from Thanjavur, and he has done a lot of work on this topic in the past as well. So we are fortunate to have him to speak about this issue in our practice.
So thank you, Mahesh. Thank you so much for the kind words, and thank you, Pachore sir, for giving me this opportunity for delivering this lecture. I must at the outset say that I do have a couple of youngsters here sitting with me who are undergraduates who are interested here and listening to the lecture as well. One is my daughter, and both of them are in first year med school. So at this point in time, I have no disclosure to make. So when I talk about Braunwald, the first thing I did was, when I had to make a presentation on this some years ago, I asked my wife, and she just threw me a big book called Braunwald and said, whatever you want to pick up, take it up from this. And as it turns out, what it says is, it appears likely that many patients who develop pulmonary embolism are genetically predisposed with inherited pro and anticoagulant factors, which interact with a precipitating environmental stress to elicit overt thrombosis. So no wonder then that Ricker described a single point mutation in the factor V gene, which triples the risk of developing deep vein thrombosis. And they've also described another single point mutation in the 3 untranslated gene of the prothrombin gene, region of the prothrombin gene, which doubles the risk of thrombose, DVT. A whole lot of other authors have described several other mutations which all increase the risk of developing deep vein thrombosis, most often to do with protein C gene, protein S deficiency, etc. Now, as if this were not enough, we do have a host of acquired hypercoagulable states like, as we all know, these surgery, trauma, fractures, cancer and chemotherapy, immobilizations, oral contraceptives, long haul air travel, obesity, age, cigarette smoking, hypertension, diabetes, stroke, spinal cord injury, and damage to the vessel wall for any reason whatsoever, and of course stasis, which all contribute to the development of deep vein thrombosis. Now, when it comes to deep vein thrombosis, how do we diagnose deep vein thrombosis? D-dimer was once upon a time said to be an extremely important modality of checking for the presence of deep vein thrombosis. But the problem with using D-dimer alone as a modality is that there are a host of other conditions which can increase the levels of deep vein thrombosis, for levels of D-dimer. For instance, surgery itself can lead to a certain amount of increase in D-dimers. In addition, any thrombosis, sepsis, malignancy, pregnancy, heart failure, renal failure, and in advanced age as well, the D-dimer levels can be elevated, which can be a confounding factor. So D-dimer alone in itself is not really particularly useful. Now, Wells came out with a clinical criteria to look for the presence of DVT. Now, as we look at these, we are kind of looking at a continuum here between DVT and pulmonary embolism. Which one is which, and which is more important? For instance, if you look at Wells' criteria, Wells describes a whole list of points to which you add 1 point each. For instance, if the patient is having an active cancer, a paralysis patient with paresis or immobilization of the lower extremity, a patient who is bedridden for more than 3 days because of surgery, localized tenderness, along the distribution of the deep veins, swollen leg, unilateral calf swelling of greater than 3 centimeters, unilateral edema, collateral veins, superficial veins, alternative diagnosis, less likely or more than DVT. Each of them have 1 point each, except for the last, which if it is there, there's a minus point. And if you have a risk score of 3 or more, equal to or 3 or more, the chances of DVT are high. Now, having looked at these, now let us look at the continuum and what is pulmonary embolism. So why are we worried about DVT? Because we all think, and we all have considered thus far, that DVT as a corollary contributes to pulmonary embolism, like as if it was a direct proportion. So pulmonary embolism, of course, when we have a pulmonary embolism, when we see a pulmonary embolism, we can't forget the sudden onset dyspnea, tachycardia, tachypnea, pleuritic chest pain, hemoptysis in rare instances, and most often some amount of hypoxia, sometimes severe. We know that a post-operative patient who develops all these things is most probably gone in for a pulmonary embolism. Now, how do we correlate these levels? Of course, D-dimer, as we already mentioned, is not really an entirely dependable entity in itself, but then you mix it up with Doppler ultrasound. You can take an ECG. You can, of course, take an echocardiography. Now, despite being married to a cardiologist for more than 20 years now, I've not really picked up the nuances of ECG, as I said, as I always have thought, and as Guru once said, double-blind studies with 2 orthopedic surgeons reading an ECG, and a single-blind study is 1 orthopedic surgeon reading an ECG. But for those of us who are intellectually inclined and who can read an ECG, these are the findings for you. And if you have any of these, then you obviously think about pulmonary embolism. Now, and these are all quite classic. Quite often, I've seen, at least on a few occasions, when my wife looks at an ECG and says, this is pulmonary embolism, and quite often she's right. So now, why are we worried about these things, and how significant are these findings? Now, it has been suggested by authors like Geertz, like that without mechanical or chemical prophylaxis, asymptomatic DVT, I again stress the word asymptomatic DVT, occurs in 40 to 60% of total hip and knee arthroplasties. Again, are Marcellus, these guys suggest that the incidence of proximal vein thrombosis is 15 to 25%, and the incidence of fatal pulmonary embolism is 0.5 to 2% after major surgery. Now, is there a disconnect there? A proximal incidence of DVT of 25 to 15% to 15 to 25%, but fatal pulmonary embolism of 0.5 to 2%. Let us go through the slides before we take a call on that. Again, incidence of DVT up to 66% of the total knee arthroplasty, any elective knee surgery, the incidence of DVT of up to 52% after hip surgery, after hip fracture, 44%. These are all remarkable numbers and massive numbers. They are quite scary to look at them directly as it is. Now, it is also, again, let's look at the disconnect here. Only 50% of the proximal vein thrombi and 5% of the calf vein thrombi are symptomatic. Again, let us remember this slide as we go on further. So we have become desperate to prevent it. And how do we do it? We were driven into desperation. In fact, probably if you had one case of one post-operative patient die on you of deep vein thrombosis and pulmonary embolism, you will never forget that patient all your life, because all your best work, your fantastic work operatively, can be brought down to absolutely nothing because a vein killed you. So we have a host of modalities by which we can prevent these. For instance, low-dose heparin, the TET stockings, for instance, to make sure that the veins don't distend and the veins are pushed up. Low molecular weight heparin, warfarin, aspirin, Lomodex has been suggested in certain instances. The physical modalities include elevation, early ambulation, graded compression stockings, pneumatic compression devices, and electrical stimulation of the muscles. So let us look at these one by one. Warfarin. Warfarin basically works on all the vitamin K dependent factors. For instance, those are factor 2, 7, 9, and 10. I'm sure the guys who are reading physiology here should be able to understand that better at this point in time. So what warfarin does, it decreases the prevalence of DVT by up to 60% and proximal vein thrombus by about 70%, according to certain authors. The massive advantage of warfarin is it is really dirt cheap. But the disadvantages are significant. For instance, it does need regular monitoring of the prothrombin times and the INR. And there is a time lag of about 4 to 5 days before which the action of warfarin kicks in. And if you are going to depend on warfarin alone, and if you're really particularly worried about preventing deep vein thrombosis, then you will have to bridge that gap with some alternative modality like low molecular weight heparin. And there is also a significant risk of about 5% risk of major post-operative bleed. And warfarin has a host of drug interactions through the cytochrome P450 system in the liver. And most of our post-operative patients are going to need some kind of NSAID therapy in order to minimize pain. And if you're going to mix that up with warfarin, there is up to 13% increased incidence of gastric bleed. And it has been suggested that it is less efficient than low molecular weight heparin in terms of preventing DVT. But if warfarin is your guy, then the target INR that you need to watch up on and try to maintain is about 1.8 to 2.5. So heparin, unfractionated heparin is what we're talking about. Unfractionated heparin acts on a host of factors. It interacts with antithrombin 3 to inhibit thrombin factor 9 and 10A. The problem with heparin alone is that if you're going to depend on heparin, you need to follow up with the APTT, because only 30 to 40% of heparin is bioavailable. The rest is absorbed or attached to plasma proteins, to the vessel walls, and the endothelium, etc. More importantly, the downside with heparin or unfractionated heparin is the production of antiplatelet antibodies, which can end up leading to issues associated with thrombosis and the thrombotic bleed as well, and leading to thrombocytopenia, which is called heparin-induced thrombocytopenia, which we have to be on the watch out for. Now, the advantages of low molecular weight heparin, it can be given as a subcutaneous dose. It works only on factor 10A. It has got a better bioavailability than heparin alone, which is about 90%. There is a reduced binding to plasma proteins in the vascular endothelium and other circulating cells. It's got a prolonged circulating half-life. If you're giving heparin alone, you will have to give it something like 6th hourly to 8th hourly. But low molecular weight heparin can be given at 12th hourly or if you're just depending on in prophylaxis or pure prophylaxis, it can be even given once a day. It has got consistent effects despite patient weight and variation, so you need not really bother too much about moderating the weight doses. But of course, if you're looking at enoxaparin, it is available in 0.4 and 0.6 mL. And more importantly, you don't really need to bother about lab monitoring of APTT, or PT or INR when you're using low molecular weight heparin, which is a significant disadvantage. So again, the incidence of heparin-induced thrombocytopenia is remarkably less. I think it's about 4. I think the statistics is about 4% with heparin alone, and it's just much less with low molecular weight heparin. However, there have been certain suggestions that in the presence of renal insufficiency, one may have to be a little bit cautious when giving low molecular weight heparin. However, the nephrologists in recent times suggest that there's nothing much to do with it. If you want to give, go ahead and give. Now, there has been suggestions of a slightly increased risk of major bleeding episodes compared with warfarin, and reduced and those, but then the chances of proximal and deep vein thrombosis is all reduced apparently by about 70%. Now, when it comes to the risk of bleeding, now you do occasionally, when you give low molecular weight heparin, you do see those patients in the postoperative period whose wound on the 5th day or 6th day, when you do the first change in dressing, does tend to bleed. And that quite often happens when the patient is on warfarin or heparin or something like that. Most often low molecular weight heparin. You stop the heparin and quite often the bleed subsides in the subsequent days. So when it comes to low molecular weight heparin, we do have a few molecules in the market. The commonest molecules are enoxaparin. If you're giving enoxaparin, do not give it before 12 hours post-op. If you're desperate and you want to give something earlier than that, then dalteparin is a molecule which has been suggested that it can be given up to 4 hours immediately after post-op. Again, fondaparinux is a synthetic analog of low molecular weight heparin. Again acts through factor 10A. Modalities are pretty much the same and nothing much different from low molecular weight heparin as such. So what are the other agents that we have? We have aspirin, about which we shall talk about a little bit more later. And then there are these newer kids on the block, rivaroxaban, apixaban, and dabigatran. So what are these newer oral anticoagulant agents? Dabigatran is a direct thrombin inhibitor, while rivaroxaban and apixaban are again factor 10A inhibitors like low molecular weight heparin. Versus this advanced trial, which compared the effects of apixaban with low molecular weight heparin, does suggest that the intravenous thromboembolism rates with treatment of these two molecules are pretty much the same in the postoperative period. But more importantly, the advantage of apixaban is that, or on any of these molecules for that matter, in fact, is that they can be taken orally, unlike other molecules. Now, between these these three molecules, for instance, it has been suggested that the dabigatran, which is a direct thrombin inhibitor, apparently has higher incidence of bleeding, which have been described by certain centers. More importantly, the chances of being able to reverse this bleeding is slightly less compared to heparin. What about aspirin, and how good as a molecule is it? The suggestions have been on and off at times. For instance, there's been a confusing suggestion that the incidence of distal DVT is slightly more with the aspirin compared to proximal DVT. So it may be more capable of preventing proximal DVT and things like that. But basically, I think these suggestions didn't really have much validity to them. The Geer et al. Again compared the effects of aspirin quite some time ago, and they suggested that it was better than elasticated stockings alone, and definitely better than placebo, but it was inferior to low molecular weight unfractionated heparin, warfarin, etc., and etc. Now, how long, if we are going to give anticoagulant therapy to these patients in the postoperative period, how long do we need to give it? So this is one analysis which suggests that the hypercoagulable state in the postoperative period lasts up to 35 days following a total hip replacement. So if you are particular and you're looking at a patient who's got a high risk for surgery and high risk of developing DVT, and you need to anticoagulate them, then you may have to go up to 5 weeks postoperatively. So again, this is another suggestion which suggests that pulmonary embolism is nearly twice as common in patients who have not been given prophylaxis compared to those who have been given prophylaxis for 5 weeks. Now, I would take this with a pinch of salt given what is going to come next. So let me skip this slide for now. So basically, at this point in time, we look, until now, as you can see, we've been pretty much driven to the wall and we are a little worried and we are scared about DVT. Mind you, when you have lost a patient because of DVT, it is an absolute nightmare in the post-operative period. We really don't want to look at a situation where an operation has been a fantastic success, but the patient unfortunately dies. So never underestimate a killer. Now, before I go on a little bit more, there is something, what do we do if a patient does have pulmonary embolism? The options are, there is an option of thrombolysis. Of course, it is reserved for life-threatening cases of pulmonary embolism accompanied by hemodynamic instability, or when there is right ventricular dysfunction, even when the patient is hemodynamically stable. The agents used, of course, are streptokinase, alteplase, reteplase, etc. But the problem for us orthopods is that it can lead to massive bleed if given in the first few weeks after surgery. I have had patients who ended up having a deep vein thrombosis in the postoperative period. They were doing quite fine, but then they end up going to another center where thrombolysis was done. They developed a massive hemorrhage in the operative period, in the operative site, even 2 weeks after surgery. So I wouldn't recommend a thrombolysis in at least about a few weeks down the line before surgery has been completed. What about the role for inferior vena cava filters? Now, it has been pretty much overhyped over some time. There have been centers which have been doing this right, left, and center, but then it comes with its own problems and it comes with its own indications. For instance, the only indication probably for inferior vena cava filters would be a specific contraindication to anticoagulation therapy, if at all there is any, or when there has been a pulmonary embolism despite full anticoagulation at the maximum dose possible, or when you're really worried about a free-floating thrombus in the proximal veins, probably in the abdomen, with the edges of the vein unattached, the thrombus unattached, you're really worried about a displacement there. So, and especially when there has been a poor cardiopulmonary reserve. Now, inferior vena cava filters do come with their own problems. For instance, even after the insertion of inferior vena cava filters, there can be pulmonary embolism in about 5% of patients. So it doesn't really protect all of them, and it can also migrate, contributing to its own problems. So why we as orthopods are particularly worried about DVT? Because we pretty much do everything on the table to make sure that our patients, develop some amount of venous thrombosis. For instance, when we do a total knee replacement, we can't push that knee into any more flexion than the patient ordinarily would in real life. We also sublux that knee, kicking that vein a little bit further. What we do there is that probably contributing to some amount of intimal damage. And then we use a tourniquet quite often, which again leads to venous stasis. Even the acute flexions contribute to venous stasis. So we pretty much do everything that Virchow described in his triad to contribute to deep vein thrombosis. In addition, as if this was not enough, most often our anesthesiologists insist that patients undergo starvation in the preoperative period, which has changed now. For instance, our anesthesiologist now says if I'm posting the patient for about 7 o'clock or 8 o'clock in the morning, the anesthesiologist is absolutely fine with the patient drinking water alone up to about 5 in the morning. He just asks 2 to 3 hours of no water at all. But of course, other than water, nothing else has to be there. So that way we can manage the hemoconcentration part. And most often we orthopods have a fancy for immobilizing our patients in the postoperative period. Again, may lead to venous stasis. Plains et al. Suggests that the very fact that there is blood loss during surgery itself can lead to a reduction of antithrombin 3 and an inhibition of the endogenous fibrinolytic system, promoting a hypercoagulable state. Sharrock measured the various levels of multiple markers of thrombin generation during surgery and during total hip replacement, and what they suggested that the maximum amount of production of these markers was during the actual preparation of the femoral canal and the insertion of the femoral stem. Now, Maynard did a contrast venography 24 hours after a unilateral total knee replacement. and demonstrated the presence of distal deep vein thrombus in up to 45% of 42 legs and a popliteal vein thrombus in about 5% of 41 legs, which means up to almost 50% of our patients are coming out of the operating room with the thrombus in their leg, which is quite scary. So given all these things and the fact that there was no real correlation and no real guidelines as to how to manage, the ACCP, the American College of Chest Physicians, came out with a set of guidelines in 2008, which kind of became a Bible for some time. They basically graded their recommendations as to grade 1 and grade 2. Grade 1 recommendations were those which were based on having a strong basis to indicate that the benefits outweigh the risks, burdens, and cost, risks, and burdens. And grade 2, of course, were those which were based on less certain studies of less certain magnitudes, risks and burdens and costs. The grade 1 were subdivided into 1A, 1B, and 1C. 1A, of course, was the gold standard, which requires the presence of randomized controlled clinical trials of consistent results. 1B was based on randomized controlled clinical trials with either inconsistent results or major methodological weaknesses. 1C, of course, were observational studies and based on observational studies or generalizations. Now, based on these, what they recommended was their only 1A recommendation was for warfarin with an INR of 2 to 3, low molecular weight heparin, and fondaparinux. Now, that led to explosion of the use of low molecular weight heparin, and we thought that was the way to go. There were a few issues with these guidelines. Now, if you look at these, basically these guidelines were based on these guidelines to come to the conclusions which were included in these guidelines. The scientists there used basically only venographically proven DVT as the endpoint. The question was, how significant is just the presence of DVT in the clinical setting? The corollary is, are we worried about DVT or are we worried about pulmonary embolism? As we just discussed in some of the older slides, now some patients have up to 60% of asymptomatic DVT. Do we need to worry about that? Now, given these issues, Parvisi looked into these issues in 2010, and what he suggested was that there is an extremely poor correlation between the presence of DVT and the incidence of pulmonary embolism. And what we as orthopods are worried about is more pulmonary embolism rather than DVT. Now, there are other issues with the ACCP guidelines. For instance, they defined major bleeding as that which was associated with death or life-threatening, significant retroperitoneal, intracranial, or intraocular bleed, or when those needing transfusion of more than 2 units of blood and a decrease in hemoglobin of more than 20 grams per liter. Now, as orthopedic surgeons, how often are we going to see those issues in our patients? Probably not. Now, other major hospitals which decided to shift to the 1A protocol, like the Barnes-Jewish Hospital, they had a protocol which they were following earlier. For instance, they used to give a short course of Coumadin with a target INR of 2, and pre-discharge ultrasound screening for DVT was done, and if no DVT was demonstrated, they would withdraw the prophylaxis. And they said they had excellent results with 1 pulmonary embolism and no death in over 700 total hepatoplasties and less than 2% symptomatic venous thromboembolism. However, they said that when they shifted to the 1A protocol, they stopped routine ultrasound screening before discharge. They put their patients on 10 days of low molecular weight heparin and suddenly found that their results were actually poorer. In fact, they were so perturbed by the results that they were getting that they discontinued prematurely the use of the 1A protocol and their study because of a high number of complications. So given all these issues that we were facing, like our issues that we are facing with the 1A protocol, was the incidence of bleed and problems of wound healing and wound adhesions, and as a corollary, infection. So given these issues, the AAOS, which set up its own work group, which looked into all these issues, basically did one important thing. They shifted the endpoint of analysis from the mere presence of DVT to a focus more on pulmonary embolism, death, or symptomatic DVT. And sure enough, and when they came out with their guidelines, the only strong recommendation that they could give for with regards to DVT was against the routine use of duplex ultrasound for a screening of these patients with DVT, because ultrasound is not really a great modality for identifying distal deep vein thrombosis. In fact, the sensitivity of Doppler ultrasound in picking up distal deep vein thrombosis is only about 27%, which means a large majority of them being missed. Now, they could find only moderate evidence for any of the pharmacological agents or the mechanical devices, including aspirin. They found absolutely no evidence to suggest that one prophylactic strategy is superior to the other, including low molecular weight heparin or the orals or aspirin. And what they suggest is that the decision on prophylaxis should be taken by patients and physicians in consultation with each other. More importantly, when it came to the use of IVC filters, they could not come to a conclusion at all as to whether there is any reason to use these IVC filters at all. So when these issues came up, and the ACCP as well re-looked into those guidelines, and then they also did something remarkably important. They shifted their endpoint as well from accepting, and then ended up accepting symptomatic or fatal pulmonary embolism as endpoint, because the presence of DVT alone appears not to be much of an issue to worry about so long as we don't have pulmonary embolism. And they revisited their guidelines and then reissued their new guidelines in 2012. And strangely enough, again, their 1A recommendation was absolutely no intervention at all, because none of the interventions would receive 1A intervention. But for 1B grading, included all the available chemical prophylaxis methods. And strangely enough, aspirin makes a comeback, because aspirin was not even mentioned in the previous recommendation. And 1C, of course, was the intermittent compression devices. So how good is aspirin alone? We know that it is absolutely cheap. It's easy for the patient to take. It's an oral tablet. And unless the patient is having any allergy to aspirin, it is an extremely safe agent. So how good is aspirin alone as a modality prophylaxis? Is it cheap, and is it good enough? Dave Beverland did this analysis where he looked into the results of the use of aspirin alone for thromboprophylaxis in more than 11,000 patients. And they published results which suggested that aspirin was no inferior to published results in terms of preventing DVT. So we know that there is a sense of despair when the best work in the operating room is lost to pulmonary embolism in the post-operative period. And there is a desperation to try and do everything possible to prevent it. And as I said, individual experiences matter. Once you have had one patient dying on you in the post-operative period due to DVT, you kind of become neurotic, and you tend to overtreat all your subsequent patients. In conclusion, prophylaxis for DVT is perhaps an individual choice a consultant needs to make in discussion with his patients. Between the various pharmacological agents, there is no evidence to suggest one over the other, including aspirin. Early mobilization is perhaps least harmful, and it is suggested by consensus. Pneumatic pumps, there is no clear evidence, but may be used because at least it's harmless. There is again no evidence to suggest that IVC filters make a real difference in terms of preventing deeper thrombosis. And to these, I should add another thing. What the AAOS conclude is that the most important factor, the only clear evidence to suggest the possible incidence of DVT is a history of DVT, a previous history of DVT in either the patient or the family. If either of these are there, then you better treat these patients. If there are other serious indications, like, for instance, a post-cancer patient who's got a high risk of deep vein thrombosis, a post-radiotherapy patient who's got a high risk of DVT, a patient who's on chemotherapy who's got a high risk of DVT. These are all patients, and a massively obese patient, or probably an obese patient where you end up doing a bilateral, or any patient, for example, where you do a bilateral. There are perhaps clear indications for treating them with anything more than aspirin. But if you are looking at a straightforward patient with a total knee replacement or total hip replacement, perhaps if they have no other comorbidities, there is no other indication like any of the high-risk factors of developing DVT, perhaps aspirin alone will do. Thank you.
thanks, Leo, for an exhaustive discussion or talk about DVT prophylaxis. So unfortunately, I can't see the chat box as I'm driving. So would you be able to see if there are any questions in the chat box, Leo?
Yeah, I'm trying to open my 1 minute.
In the meanwhile, Dr. Pachore, do you have to make any comment about?
Swapnil Vadya has asked, any recommendation pharmacological option available in your routine practice? So what's your recommendation? What do you use in your practice?
At this point in time, most often, as I was a regular user of low molecular weight heparin. But then most often I end up seeing this bleed in the 5th day, 6th day, there is bleed, and I'm a little worried, so I end up stopping it, and then you always see that the bleeding, everything stops, and the wound goes into healing. So at this point in time, aspirin. And if I'm doing a bilateral, if I'm looking at a massively obese patient, then I quite often put them on low molecular weight heparin. My concern with the newer oral agents is that how long they take for the effects to go away, and especially the dabigatran has got certain issues which I'm concerned with. So at this point in time, I would stick to aspirin. I think that's the simplest, cheapest agent one can find.
Dr. Pachore, what do you think about using aspirin as a standard prophylaxis in our patients? Do you think that's going to be safe from the medical legal point of view as well? Or would you go for any stronger agent? You are on mute, Dr. Pachore.
Sir, your mic is not. Yes.
Yeah, you can. Yeah, we can hear you.
Again, you are on mute, sir.
Can you unmute yourself, Dr. Pachore?
Sir, you're muted, sir. Yes, sir. You're good.
Okay. Can you?
Yes, sir. Yes, sir.
Yeah. Aspirin is, there is no question that it has been now well recommended, but I don't know how far it is legally helpful for us. I don't know that concern. But one thing I want to just point, 2-3 things I want to point out is our teacher used to tell that Asians do not develop a DVT. And I must thank Dr. Sanjay Agrawala, who was the first study from the country to prove DVT. And what he did, he took about 100 patients plus hip and knee both. And all patients went through a venography and not only a Doppler. And to our surprise, it was almost, I don't remember exact figures, but it was, I think, around 40% or plus had some DVT. But fortunately, they were all distal DVT. Proximal DVT was not that high. But that proved that the Asians do develop DVT. Regarding the filter, we used to use a filter very regularly for a couple of difficult patients. But now what Leo said is right. One more indication, Leo, in a filter is the patient who is throwing repeated embolism. Some signs like a cerebral anoxia, a few things, these are the people who need. And this only prevents, Leo, a massive DVT, minor thromboembolic phenomena still will continue from this the sieves. So that is one another thing is there. What about the Leo? Any antidote for the suppose the patient starts bleeding with the oral drugs? Have you got any antidote? Because LMW, if you stop 48 hours, probably we are able to control. What about these oral drugs?
So that's the only concern, sir. So heparin, we can always give protamine sulfate. Low molecular weight heparin, you stop it. Yeah, low molecular weight heparin, 12 hours, the effect goes away. Warfarin, give injection vitamin K, the effect goes away. Aspirin, stop in about 3 to 4 times. In any case, the anticoagulation is not that severe. But the oral agents do not have an agent which can reverse the effect. So that is the only concern at this point in time. So if you end up having a catastrophic bleed in the post-operative period and you're a little worried, you don't have much of a control with the oral agents. Now, the argument is that the incidence of oral bleeding is less with rivaroxaban and apixaban. But then, companies, they market themselves, and I think at this point in time, there's not much of an evidence to go for it.
Okay, any further questions? Neeraj, do you want to add something?
Nothing. It was a quite exhaustive presentation, excellent presentation, Leo. And
thank you, Neeraj.
Yeah.
So the question, I think, is Mahesh, what do we do? Do we treat and prevent DVT, or do we treat and prevent pulmonary embolism?
Yeah.
And if we are treating DVT, do we need to go after every incidence of DVT, which means that at least 60% of our patients are going to need it. And the problem is that a large majority of that 60% are going to be totally asymptomatic. And probably you leave them alone, they're going to, the way the thrombi are going to slowly dissolve by the natural antithrombotic process, antifibrinolytic process, the fibrinolytic process, and then they're going to dissolve over time. So the issue is whether we treat every incidence of DVT. And I think the current consensus is one need not do that. One just need to give enough prophylaxis to make sure it doesn't go beyond a certain level. And because we then have the other issues, of the downsides of over-treating DVT in the post-operative patients.
I completely agree with you, Leo.
Yes, I agree. But I've been using rivaroxaban since almost 4 or 5 years now, and most of our cases are bilateral TKS. Barring couple of patients, just very few, 2-3 patients, we never had any issue of excessive bleeding, or then one patient had hepatic derangement because of rivaroxaban. But otherwise, excellent. But this DVT, whether it is subclinical and not, and medical legally, how it is safe if we don't address that? Literature says, but otherwise, then they are going to ask you if you don't treat it post-op-late.
I think any medical legal decisions have to be based on what scientific evidence is available. And at this point in time, I think there is enough scientific evidence available to suggest that aspirin alone is more than enough in treating these patients. So that should be all it needs is in the court of law, the presentation has to be appropriately made. The judge is basically a non-medical person who's got to take a decision on a medical issue based on what experts suggest to him. And if the appropriate experts suggest the appropriate suggestions, then I think there is enough evidence to suggest that aspirin alone is enough. Unless, of course, again, with a caveat that there is something called a high risk for developing DVT, and there are specific reasons why there could be high risk for DVT. For instance, as I mentioned, if a patient has had a previous history of DVT, or there is a family history of DVT, which all could suggest that there probably is some kind of a mutation going on in the family which could contribute to DVT, or the patient has any of the other issues like cancers and things like that, which can potentially, again, the evidence, the clear gold evidence for clear history of clear high risk for DVT could only be found with a history of DVT in the person or the family. None of the others, including cancer, chemotherapy, none of the others really achieved a level of evidence enough to suggest that they are definitely linked to DVT. But then clinically we know that these guys can throw a DVT and pulmonary embolism, so we are worried about them. So in all these cases, maybe we need to go with something higher, like for instance, heparin or any of the oral agents, whatever we are convinced with. But otherwise, I think aspirin should be enough, and we should be able to justify ourselves.
Yes. Mahesh?
Mahesh, are you there?
So I think, yes, your voice is cracking.
and thank you, Neil, for who has been the inspiration behind organizing these sessions. We have been a bit irregular, but as the exam is coming closer, we will try and do more and more session. And I hope it is useful for all the students. Please do give us any feedback time to time again on the WhatsApp group. Thank you.
Thank you, Mahesh. Thank you. Thank you, Neeraj. Thank you, Neeraj.
Thank you.
Thank you so much, sir.
Thank
you, Mahesh.
Thank you,
so much.
Pachare sir. Thanks,
Yeah.
Leo, Mahesh. Thank you. Bye-bye.
Thank you so
Thank
much.
you.
Good night.
Bye, sir.
Bye.